today is very much about exercise, and you might not think there's much exercise involved in pregnancy. You have to a little bit at the beginning of the pregnancy and quite a bit at the end. But actually, if you think about it, your heart has to exercise quite hard all the way through pregnancy. So that's just sort of try and put it in context for you. Let's put the whole thing into context. Is pregnancy a safe thing? If you live in the developed world, pregnancy is incredibly safe. And in the UK, there have been confidential inquiries into maternal mortality since the 1950s. So we know very clearly how many women die. And deaths related to pregnancy have fallen decade upon decade. And so now our most up-to-date data show us that only 10 per 100,000 women given birth die. That's amongst the lowest in the world. But if you look at why they die, it becomes much more interesting. 2/3 of the women that die in this country from pregnancy die because they have a medical condition. Only about 1/3 die because of the pregnancy itself, so from bleeding or infection. If you look in the developing world, that's very much the opposite, and nearly everybody dies from something to do with the pregnancy rather than from an underlying medical problem. If we look a little bit more into this purple group who have medical conditions, heart disease, which is this column here, is the single biggest cause of maternal mortality. This slightly taller column is a mishmash of all the other medical conditions that didn't score highly enough on their own to get on the graph. So heart disease is way ahead of anything else in the causes of death. And sadly, it's going up. If you look at many of the other conditions, like psychiatric disease, which used to be very common, interventions have come along, very simple ones, asking the mother how she feels, and if she's feeling low, you look after her carefully, reduces maternal death. We've not achieved anything like that for heart disease in pregnancy. Let's look then about what heart disease is killing people. And this is from the most up-to-date data that we have available. There'll be more data will be produced on the next lot of data probably by the end of the year, beginning of next year. Ischemic heart disease and systolic ventricular dysfunction of any cause, so any sort of cardiomyopathy. This doesn't include hypertrophic cardiomyopathy, and peripartum cardiomyopathy are the commonest causes of maternal death. You'll spot also, close to Christ's heart, is that sudden adult death syndrome is also one of the commonest causes of death. In this short talk, I'm not going to talk about hypertrophic cardiomyopathy. It's very interesting in pregnancy, and the physiological responses are fascinating, but it's a much less common cause of death. So I felt it was more important to talk about systolic dysfunction, in effect dilated cardiomyopathy. If you think about these women who die of heart disease, where was your opportunity to stop them dying? And you ask yourself, well, did we know that they had heart disease before they died? And for the great majority of women, that is not the case. This is fairly old data from the 70s up until the beginning of this century, looking at the women who died from heart disease. And the majority of women who had, the minority of women died with known heart disease, and deaths have not increased in this group. The women who are dying either have no risk factors or just are presented as a surprise during pregnancy, either by dying or with symptoms that were either not recognized or could not be treated. So if you are talking about counseling a woman before she gets pregnant, we're talking about this relatively small group of women who would have gone on to die. When any woman wants to talk about pregnancy, you must, of course, talk about healthy living, taking folic acid, not smoking, and exercising. But if you're talking about somebody with a heart condition, the woman needs to have information so she can make an informed decision about what she's going to do. It's not our role to say you can or cannot have a pregnancy, because she's going to do what she wants anyway, and if you say that, all you'll do is alienate her so she doesn't come back to you for care. So our role is to let her really understand as best she can what might happen to her if she gets pregnant. you have to think of what effect her heart disease will have on her pregnancy, both for her and for the fetus. The heart disease might mean that her pregnancy has to end early, and that obviously can have a negative impact on the pregnancy. The heart disease, on the fetus, sorry. The heart disease may progress and the fetus may not grow so well because of placental insufficiency. Then you look at the reverse. What effect may the pregnancy have on the woman's heart disease? And then we're talking about the risk of dying and the risk of acute or long-term deterioration. She may also want to know whether these effects will change with time and treatment. So for many women with heart disease, we can do an intervention to reduce her risk. So say, don't get pregnant now, we'll replace your aortic valve, then you can have a nice low-risk pregnancy. Unfortunately for cardiomyopathy, that's often not the case. And so a woman coming to see you, you may say, well, do you know what? Today is your lowest risk. So what I tell you today is the best it's ever going to be. And that's very important for women. And particularly if I'm seeing somebody young, I may well say, don't put your pregnancies off until you're 35. Don't go and have a one-night stand just to get pregnant. But when it's the right time for you, you're probably not the woman who should delay a pregnancy for your career or for social reasons. If your dearest wish is to have a pregnancy sooner, it's going to be less risk than later. And she needs to have some understanding of her long-term outlook. If she knows that her life expectancy is low, is short, it may have an impact on whether she decides to have a baby or not. And very importantly, she needs the ability not to get pregnant. And so one of our roles is to be able to advise her on what sort of contraception is safe for her heart and is going to be suitably efficient so that she doesn't have an accidental pregnancy. So the risks to the mother, death, which we would hope to prevent because we're going to follow these women very carefully, and if she starts to deteriorate, we will intervene, and if that intervention is to make her not pregnant anymore, then so be it. But she may have cardiovascular complications during pregnancy, she may develop overt heart failure or an arrhythmia. She may be at increased risk of hemorrhage because of medication and from thromboembolism, both of which she will tolerate less well than a woman with a normal heart. There's also a concern that she may have an irreversible deterioration in her ventricular function, and that's very difficult to predict. That may manifest itself as being in a worse functional class after her pregnancy, and that can be quite difficult to judge because every woman feels awful after she's had a pregnancy and she's got a baby that she doesn't quite know how to deal with and she's not been to sleep for 3 months. But nonetheless, functional class may reduce. Thank you very much. Her prognosis may be adversely affected. If her ventricular function is worse at the end of the pregnancy, it very often doesn't get better, so her long-term outlook may be worse. And for the woman for whom it goes really badly wrong, she may end up, as a result of her pregnancy, needing mechanical support or transplantation. Women are always more worried about what's going to happen to the baby than they are about what's going to happen to themselves. She needs to know what the chance is of the baby dying, and often that is what is the chance of us having to deliver her before the fetus is viable. She needs to have an understanding of what extreme prematurity means. She needs to know that her baby may be small, and we need to look at all her drugs, because most of the drugs that cardiologists like, fetuses don't like very much. And it also means if you're going to stop somebody's ACE inhibitors or ARBs or spironolactone, which is what you would have to do when she gets pregnant, just that act in itself may make her deteriorate. You can manage always anticoagulation with low molecular weight heparin, and beta blockers have a bit of a bad press, but really they are pretty safe in pregnancy. She needs to understand her recurrence risk, certainly if she's got hypertrophic cardiomyopathy or a familial DCM. And we should also consider, although we don't talk about it much as non-holistic cardiologists, that the fetus may struggle from poor bonding with its mother and from lack of access to breastfeeding if the mother's unwell at the time of delivery and she doesn't get to see it and really relate to it. So if we want to provide an accurate risk, we need to understand what the physiological demands of pregnancy are. We need to look at the various risk scoring systems, which I have to say I don't think are particularly useful. We need to look at maternal mortality data, which we've done. Bad ventricles do badly. The guidelines, and the most up-to-date ones we have, are from the ESC from 2011. We need to see if there's any lesion-specific data out there. Very often there's certainly no randomized controlled trials in pregnancy, so often the data are just registry data. And remember that risks are additive. So if you're a woman with a dilated cardiomyopathy is also obese, hypertensive, and diabetic, her risks will be much higher than if she's slim and fit and leads a normal health and leads a healthy lifestyle. For me, this is the crunch slide. This is what your circulation has to do when you're pregnant. Not only does your heart have to increase the cardiac output by 50%, but it has to do it pretty much by the end of the first trimester. And that means that you can now all do my pre-pregnancy counselling clinic, because we can all work out whose hearts we think is going to be able to achieve that. And that's why women with poor systolic function, with poor systolic function do so badly in pregnancy. Most of the increase in cardiac output is achieved by an increase in stroke volume. So if you have impaired contractility, you're not going to be able to achieve that. So scoring systems, this is the modified World Health Organization scoring system, which you'll see it has my name as the original reference. A bunch of us sat in a room with a piece of paper and wrote down what we thought was the highest risk. That's the level of science behind this. But the other risk scoring systems that have been based on registry data, when you then try and apply them to real life, this is what works the best. It's not very good, I'm afraid. And we split the risk of pregnancy to class 1, where we think the risk is the same as everybody else. Class 2, we think there's a small increased risk. Class 3, a really significant risk of mortality and morbidity. And these are the groups that really need specialist care. And then the very high risk, this is the group where you would say, please consider not having a pregnancy. So what about cardiomyopathy? Where does that fit? Somebody who is well and just has mild left ventricular impairment and no other problems will be in class 2 or class 3. I would put most of them in class 3. I think you can never be too careful with ventricular dysfunction in pregnancy. And you'll see most hypertrophic cardiomyopathy will fall into this condition, into this group. Class 4 is anybody with severe systemic ventricular dysfunction, so ejection fraction of less than 30%, and anybody who is already symptomatic before they get pregnant. It's kind of not rocket science and what you would imagine. So if you see somebody who you know has a cardiomyopathy, how are you going to assess them? Well, the history is important. What's the family phenotype? What's happened to other people in the family with your condition? Is she asymptomatic? Is her left ventricular function stable? If you have a woman who, say, had chemotherapy when she was a child and took one hit to her ventricle and then stayed stable for many years, she might be at lower risk than somebody who's got a progressive condition of familial cardiomyopathy. You may also want to give a trial of stopping the teratogenic drugs that she's on before you really assess her. As if she's on ACE inhibitors and spironolactone, you will stop them when she gets pregnant. So why not stop them beforehand for a couple of months and assess her once she's not on them anymore, so you get a better idea of how she thinks she's going to fare. It's really important to have good documentation of your examination findings, because you may need to refer back to them as you follow her up during pregnancy, and it'll be much easier to pick up subtle changes. Echo, obviously, very important to assess her ventricular function, and we usually combine echo with an exercise test so that we get exercise echo data. And we use her exercise capacity, her ability to put up her blood pressure, her response of her ventricle, does the contractile reserve increase, what happens to her pulmonary artery pressures. All of that is really helpful in giving you an idea of how you think she's going to fare during pregnancy. And then you make a plan. I would say pretty much all women with impaired ventricular function need to be looked after in a specialist joint obstetric cardiac clinic. You need to be flexible because you need to change your plan if her condition changes. She needs to know who to contact as soon as she gets her positive pregnancy test. If she's anticoagulated, you're going to need to change her drugs, and the quicker she's into the system, the better. How her pregnancy progresses will dictate on how you look after her, but you have to think about balance of risk. Is she going to be better off looked after by a good but less experienced local team, or in a specialist centre many miles away, which runs the risk of, if she gets taken ill or goes into labour rather quickly, she may end up delivering on the motorway somewhere, which is never the best place. Apologies for the voice. You might also need to consider whether it's likely that she's going to need antenatal admission, early delivery, and how you're going to deliver her. The least cardiac strain is a normal vaginal delivery with good analgesia and a low threshold for forceps. Achieving that can be quite difficult, but that should be your aim because that's going to be her safest option. And then you need to consider the specific issues about her drugs, and if she has an ICD or a pacemaker, how you're going to manage that in labour. So we'll have a case history now. This is a 28-year-old teacher who was referred at 38 weeks gestation in her second pregnancy. Been completely fit and well, had a baby 2 years ago, completely straightforward. And at 35 weeks, she developed a widespread erythematous eruption, a skin rash, a bit of a fever, and was a bit breathless. Got gradually worse, and she was admitted to the local hospital, to the medical ward, with this desquamating rash that was very concerning. She was getting more breathless, her heart rate was consistently more than 100 beats per minute, and she had lots and lots of tests, very clever blood tests, skin biopsies, steroids all over the place, and she was getting more breathless and more orthopneic. She saw lots of clever doctors, physicians, dermatologists, rheumatologists, immunologists, and it wasn't until she was 38 weeks and too breathless to go to the bathroom with a heart rate of 130 and a pulse of 90 that somebody thought perhaps doing an echo wouldn't be a bad idea. Now, obviously, it's a Friday afternoon. And so the local cardiologist was called into the echo room, saw the echo, and gave us a ring. So she had a dilated left ventricle with poor function. And so she arrived about 8 o'clock on Friday night, and we had the consultant obstetrician, cardiologist, and obstetric anaesthetist, and she was sent straight to our high dependency unit in the labour ward. She was very frightened, breathless, sitting forward, that fairly unpleasant sign when your heart rate's higher than your systolic blood pressure, bibasal crackles, a little bit of edema, and her rash was resolving. We used the obstetric ultrasound, and she had an enormous ventricle that was barely moving. The ejection fraction was around 15%. She had broad left bundle branch block, she had sinus rhythm, but had a lot of ectopy. The baby was alive, so we now have to make a plan. So we'll have some hands up, just because it's after lunch and you need to stay awake. Who thinks it's a good time to deliver the baby? Who wants to get the baby out in labour ward? Who thinks a bit of cardiac ITU might be a good place to go? That's what we thought. We felt she was really very sick, so we took her and put her sort of semi-electively, put a balloon pump in because we felt she may really decompensate when we delivered her. In the interests of speed, she had a general anaesthetic. We didn't want to wait for an epidural to work, and we certainly weren't going to go in with a spinal that would have made her decompensate. Baby was fine. The mother really didn't look great. We thought she would pick up after the baby was delivered. There wasn't a lot of blood loss. It was all a very smooth section, but she still looked really bad. 12 hours later, balloon pump, adrenaline, blood pressure's not great. She's getting more acidotic, and she's getting runs of ventricular tachycardia. It's not good, is it? So she had an emergency LVAD, and she was well with that, and we have pictures of her cycling by her bedside with the LVAD on about. And her ventricle recovered completely within a week, and we took the LVAD out again. That was very difficult. We had her on the urgent transplant list at the same time, and it was, are we going to take her off the list? If her heart comes up today, are we going to give it her? No, and we took the LVAD out. 3 years later, she's fine with a completely normal ventricle. We did more clever blood tests and biopsies. We never got a diagnosis. But our advice to her is, please don't have another pregnancy. This was not a peripartum cardiomyopathy. She had some inflammatory response, I'm sure, and that's why she was lucky enough to recover. It's pretty unusual to recover, I think. Most people who end up with an LVAD are unlikely to make a full recovery, but she came quite close to the edge. So just as a summary, this slide is very busy, but it is in the PDF. I think you can have access to the slides afterwards. Just to make you think, what's the difference between normal pregnancy and heart disease? Every woman who's pregnant is breathless. She can't sleep. Her heart rate's fast. She gets a bit of chest discomfort. They faint. They have syncope. They get palpitations. You need to be able to understand the difference between normal pregnancy and heart disease, and mostly it's in how you take the history. It's in the pattern of the breathlessness. It's in the pattern of, well, why can't you sleep at night? Is it the bump, or are you really orthopneic? What's the heart rate? If it's less than 100, you're probably not so worried. If it's consistently more than 100, you should be worried. So it's getting that balance and making sure that the history you take is really good. Common themes when we look at maternal deaths and maternal near misses in the confidential inquiries are that the symptoms and signs are misinterpreted. And it's either, this is normal for pregnancy, we're not going to do anything, or particularly when the woman is postpartum and turns up to A&E, oh, she's all a bit tired and emotional. She is tired and emotional, but she may also have serious pathology, and it's really important to get to the bottom of that. And another really important way that we see deaths and near misses happening is what happened to this lady. Is they get seen by a whole bunch of quite bright people who think about one diagnosis to the exclusion of the others, which in retrospect are always really obvious. It's her heart. And they think about other conditions, and they don't keep their minds broad enough to think about, just stand back, why is this going on? Have we not thought about something very obvious? So just to summarize, we have our known knowns, that's the pre-existing cardiomyopathies, and there the focusing is on a really careful assessment. What do we think the risks are? And then following these women very carefully. The most difficult ones are the unknown unknowns, and that's when the presentation is precipitated by pregnancy. And that's either a pre-existing cardiomyopathy is unmasked by the pregnancy, or the pregnancy causes a peripartum cardiomyopathy. These are the women at most at risk because you have to train non-cardiac teams to pick up the signs of heart failure and to act fast. And if that means in your practice that you get inundated by worried obstetricians going, oh, they've got these symptoms, that's okay. Because if you see 90 normal women and everybody's worried and you can reassure them, not a problem. If you pick up the 1 or 2 who've got really important underlying heart disease, then you prevent them becoming one of the statistics and appearing on the maternal mortality data. Thank you.